Cukup semua dah?
Dah, 38.
Okey lah, present lah.
Okay. So, Assalamualaikum. So, for the first topic today, for today's seminar is going to be about bronchial asthma, presented by me, Shafiq Shahmi. So, this will be the outline for my presentation, where we're going to talk about definition, epidemiology, and until management. So first, CPG for childhood asthma define asthma as heterogeneous condition characterized by paroxysmal or persistent symptoms such as dyspnea, chest tightness, wheezing, and cough against a background of chronic persistent inflammation and or structural changes associated with variable airflow, limitation, and airway hyperresponsiveness. Oftentimes, it is irreversible airflow obstruction, either spontaneously or by treatment. So we're going to look briefly. So we're going to look briefly on epidemiology. So asthma is the most common definition. Daripada CPG, childhood asthma.
Yeah. Okay, ha. Continue.
Okay. So briefly on the epidemiology, so bronchial asthma is the most common chronic respiratory disorder in childhood. The prevalence of asthma seems to be plateaued in Malaysia with 5.8% of children aged between 6 to 7 years and 8.9% of children between the age of 13 to 14 years. So the prevalence of asthma is higher among urban and inner city children, as for example, 7.3% on Muar to 18.9% in Kuala Lumpur. And bronchial asthma also, it is responsible for about 10 to 20% of acute admission in children aged 1 to 16 years. So next, we're going to look at the etiologies of bronchial asthma. Although there is no cause of asthma that have been identified, a combination of environmental factors and also genetic factors have been implicated. So the first one, as for environment, it is caused by infections. So recurrent wheezing in early childhood is mostly associated with viral infection, especially by rhinoviruses, common cold rhinoviruses. So apart from that, home allergens like house dust mites, animal with fur pollens, exposure to sensitized individual can initiate airway inflammation and also hypersensitivity to other irritants, and has a strong link to the disease severity and also persistence. And then environmental exposure like tobacco smoke and also air pollutants can aggravate the inflammation and also can increase the severity of the disease. And then cold air and also dry air depends on the weather, and then exercises which causing hyperventilation can induce a bronchoconstriction. As for genetics, there are studies found that those patients who have first-degree relative who are asthmatic have higher incidence of having childhood asthma. So that gene linkage will mediate the switch to IgE production, differentiation to T helper cells with production of interleukin 4 and 5, and also eosinophil production and recruitment to lung, which will mediate in the pathogenesis of asthma. So this will be the outline for pathophysiology of asthma, starting with the factors or the causes like we discussed before, which will lead to bronchial inflammation, causing edema, excessive mucus production, and lead to bronchial hyperresponsiveness, which will exaggerated to inhale stimuli and causing airway narrowing, reversible airflow obstruction, and finally lead to the symptoms of asthma like wheezing, cough, breathlessness, and also chest tightness. As for pathogenesis of asthma, it is very complex and not fully understood. It involves a number of cells, mediators, nerve, and vascular leakage, which can be activated by several mechanisms and cellular components of inflammatory response. So here is a simplified diagram as to understand the pathogenesis of asthma. Starting with the entry of allergens such as pollen into the airway, and then the dendritic cell will phagocytose the allergen and act as antigen-presenting cell and present the processed allergen to the T helper 2 cell. So, and then T helper 2 cell will be activated, causing two key consequences. As for the first one, it will activate eosinophil mediated by interleukin 5, and activated eosinophil will secrete cytokines and also leukotrienes. And then another action is that it will activate plasma cell mediated by interleukin 4, interleukin 5, and also interleukin 13. And then activated plasma cell will secrete antibodies IgE, and then the IgE will activate mast cell, which finally result in the secretion of histamine, leukotrienes, prostaglandin D2. So this process will, at the end of this process, there will be production of pro-inflammatory and also pro-allergic mediators that will cause the bronchial inflammation. So next, we're going to look at the clinical features of asthma. Firstly, for the symptoms, so the patient who have asthma will present with recurrent episode of one or more of the symptoms like coughing, wheezing, chest tightness, and also shortness of breath. Apart from that, we can also see the non-specific and also subtle symptoms of asthma like self-imposed limitation of physical activities, general fatigue due to sleep disturbance, and also difficulty keeping up with peers in physical activities. Also, there might be presence of ectopy like eczema, allergic rhinitis, and also conjunctivitis in child or family that will support the diagnosis of asthma. We can also ask about the previous experience with asthma medication. If they have improvement by using the medication, it also support the diagnosis of asthma. And then we can look at the signs of asthma, starting with inspection. There will be altered consciousness. There will also be signs of respiratory distress like nasal flaring, intercostal retractions, and also suprasternal retractions. Here is a diagram that one of the signs of respiratory distress. As you can see at the left diagram, you can see a nasal flaring. At the middle diagram, you can see here is intercostal retractions and also suprasternal retractions. And lastly, here is a diagram for the Harrison sulcus, which are associated with asthma. So apart from that, we can also see sinus, bluish discoloration of the skin. And then we can also see dry skin and eczema, Cushing features due to the prolonged steroid medication, hyperinflated chest, and also Harrison sulcus that, like I said before. And then on palpation, we can find there is decrease in chest movement and also decrease in vocal phlegmitis. As for percussion, you can find there is a hyperresonance to percussion due to hyperinflated chest. And then lastly, for auscultation, there will be diminished air entry, vesicular breathing with prolonged expiratory phase, and lastly, generalized expiratory rhonchi. So, diagnosing asthma in preschool children by the age of 6 years old is oftenly difficult. That's because about around 50% of them will have one episode of wheezing at the age of 6, and less than half of them have asthma, because most of the wheeze are associated with viral infections. So in general, there are three patterns of wheezing, which are viral episodic wheezing, multiple trigger wheeze, and lastly asthma. As for viral episodic wheezing, those children who experience this have the wheeze when they are infected or when they have viral infections. So between those episodes of infection, they do not have the symptoms. As for multiple trigger wheeze, this kind of children have a discrete exacerbations, and between those episodes, they have a symptoms of they have the symptoms. And then we have different.
Pusing balik, this one three pattern of wheezing ni bukan asma. This is maybe asthma, maybe not. It's just a condition.
Okay.
Yeah, condition of the wheezing of the child. Is it episodic wheeze or is it multi-trigger wheeze? And asthma is many of multi-trigger wheeze are asthmatic.
Okay.
So you don't differentiate. So multi-trigger wheeze is when you're not sure what the diagnosis are. Is it asthma? Is it swallow-induced wheeze? You don't know what is that. Okay, next.
As for differential diagnosis for chronic cough and or recurrent wheeze. So for asthma, it is a diagnosis of exclusion when the patient present with chronic respiratory syndromes, especially with sign of symptoms like clubbing, cyanosis, failure to thrive, wheeze, persistent wheeze after treatment, and also chronic cough. So it is important for us to also point at other conditions that might cause chronic cough and as other recurrent wheeze. As for example, like upper airway disease like sinusitis, vocal cord dysfunction, obstruction of the large airways like vascular rings and also laryngeal webs, and obstruction of the small airways like viral bronchiolitis, bronchiectasis, and lastly, other causes like tuberculosis. So for investigation, normally in younger children, a good history and also good clinical examination is already enough as to diagnose asthma. But in some cases, specific investigation we can done. For the first one is lung function test, the spirometry and peak flow. So in asthmatic patient, we expect that they will respond to bronchodilator therapy. There is improvement in the peak expiratory flow, PEF, of more than 20%, or forced expiratory volume in 1 second, which is the FEV1, more than 12%. So this, if we find this finding, it is supportive of asthma diagnosis. And then we can also measure the exhaled nitric oxide. So exhaled nitric oxide is a inflammatory marker that suggests allergic related asthma. So if there is increased value of nitric oxide, it is suggestive of atopic asthma. Also, we can do is skin prick test to common allergens, as it can aid in the diagnosis of asthma, and we can also identify the allergens that might trigger the asthma. So positive skin prick test is also suggestive of atopic asthma. And next, we can do imaging, which is the chest radiography or chest X-ray. It is indicated if we suspect there is mediastinum mass or pneumothorax, which is a complication of one of the complication of asthma, but we do not do the imaging like chest X-ray as a routine investigation. And then in atypical cases, we can also do other investigations like HRCT thorax scan, 24-hour pH study, immune function test, Mantux test, echocardiogram, as to rule out other differential diagnosis. And lastly, we're going to look at the management. For the drug therapy, it can be there are two types of drug therapy. The first one is called the bronchodilator or reliever therapy. So as the name suggests, it have been used as to improve the respiratory symptoms of asthma. The treatment of choice is intermittent short-acting beta-2 agonists. For example, like salbutamol and also terbutaline. As for the next one, we have preventive therapy. The most effective and the treatment of choice is inhaled corticosteroids. It is the most effective prophylactic therapy. It can decrease the inflammations, which result in decreased symptoms, asthma exacerbation, and also bronchial hyperactivity. We can also introduce leukotriene receptor antagonist as preventive therapy for mild persistent asthma. So this preventive therapy, the duration maintenance will depend on response, frequency of symptom, and also the acute asthma events. So progression of the treatment or step up is indicated if the asthma cannot be controlled, or the asthma control cannot be achieved using the standard dose of inhaled corticosteroid, and provided that it is used correctly. So we will introduce a long-acting beta agonist for combination therapy. It is more appropriate to use combination therapy than increasing the dose of inhaled corticosteroids. And it is also superior to add long-acting.
Not for your level. Bukan, you depend case to case basis. Certain case we double, certain case we ni dia tak payah. Don't go so long dalam management. Your punya sign symptom very short, history pun very short. Ada parti year 3 ni suka sangat masuk pergi ke management tau. Padahalnya it's not your level. Your job year 3 ni semua of sign and symptom history. Ini buat apa you nak tahu pasal batu which are more superior, which are less superior, you tak practice pun. You won't have any benefit on you at all. But the sign and symptoms tu sepatutnya 3 atau 4 slide tau. Especially the history tu panjang patutnya. My slide also history 3 slide. So, history pendek je. Lepas tu you focus on management. Waste time je. Tak payah je baca je. Tak payah cakap apa tu which are more superior, less superior. It's not for your level. Management year 3 just baca je. Don't waste time on that. We're not going to ask on you. You're going to fail if you are unable to diagnose. Tapi if you are unable to manage properly, you're not going to fail yet. Because year 5 is when we're going to start to focus a bit more on the management. Don't waste time on that. Dah baca je, tak payah lebih lagi. Because you're not going to practice at all. What you're going to practice in the ward is your history and physical finding. Anything else? Management.
Ini pun pasal management.
Okay, go this one now.
Okay. Next, we're going to look at management for acute asthma exacerbations. So before we plan for appropriate treatment, we must assess the severity of the asthma attack. So this will be the assessment. As for example, like if a patient came with a severe acute asthma exacerbation, they will have like a breathless at rest. They cannot finish their sentence. They will talk in words. They will feel agitated. They will be tachypneic. There will be presence of accessory muscle usage, and also retractions, wheezing, and others. So if we already can determine the severity, then we can plan for appropriate treatment. So one of the medication used are short-acting beta-agonists. It is the first line treatment, and then modify a metered dosage. Metered dose inhaler SABA can be delivered via spacer. So spacer is this one, as you can see. So this is the MDI. So these have the same efficacy as nebulized SABA. And then parental route of short-acting beta-agonist will be given to severe or life-threatening acute asthma exacerbation. And then oxygen. If patient is acutely distressed, we will give oxygen with SABA. Or in severe or life-threatening asthma, or when the SpO2 is less than 95%, it can be delivered via nasal pro. And then we have systemic corticosteroids. It is an effective medication as to control inflammation and as to hasten the recovery, and should be given early. So it can be delivered via oral or intravenously. So intravenous is indicated if the patient cannot tolerate oral delivery. Like for example, like if the patient is vomiting, and it is indicated if it is moderate to severe or life-threatening. And then ada
Tak payahlah. Don't waste time. Forward. Ni cukup.
okay.
Ini okay.
So like I said before, the
So
first thing we must assess the severity, whether it is mild, moderate, or severe, or life-threatening. So, and then we follow this algorithm. So I think that's all.
Go back to your signs and symptoms. Ini je. Belakang lagi. Lagi. History. Belakang. Depan. Depan lagi. Depan lagi. 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 Tak, depan tu ni. History. Ke depan ni ke belakang. Sini. Ini belakang tadi. Belakang ni. Ini je. Lagi belakang. Ini je. This is the, clinical symptoms. Future. History. Mana history? How you know asthma? No asthma from history. Tak ada. Apa you baca sebenarnya? Depan lagi, clinical feature sikit. Sign apa? Dalam you punya assessment and severity banyak pula sign dia. You tahu, you focus on history dengan tu. You spend time on history and physical examination. Asthma, you kena tahu dua things, background asthma and acute exacerbation. What we call by background asthma. Because you're from the history of background asthma, first you must know how to diagnose asthma. Second, once you diagnose asthma, you must know is it a well-controlled, partially controlled, or poorly controlled. Third, you must know how to recognize acute exacerbation of asthma in terms of mild, moderate, or severe. That's all you need to know. Ada tak apa benda you baca? Tak ada history pun tak ada. You baca buku pediatric protocol saja habislah you. You tak pandai. You baca pediatric protocol for introduction of asthma, you're going to get stupid. Because dalam tu tak ada pun how to diagnose asthma. Because the pediatric protocol only discuss you this is asthma, what to do. But it doesn't teach you how to diagnose asthma. How to diagnose asthma, to exclude the other causes of asthma. How you differentiate this asthma, this bronchiolitis, this viral bronchopneumonia, how you differentiate from that. Tak ada dalam pediatric protocol. 20 minutes you present, tak tahulah, betul I tak suka present lama sangat. Tapi you cakap slow sangat. Patutnya cakap laju, cari cakap tu relax ya. You spend a lot of time, half an hour, tapi not much is there. Okay, next presenter.
Thank you, Doctor.
I'm the next presenter, Nik Kamila Iman.
Siapa?
Nik Kamila.
Topik apa?
Bronchiolitis.
Ya. Ni Kamila apa?
Yes.
L dua satu L, 2 L.
2L. Alamak.
Present.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Now I'll continue with bronchiolitis. So this is the outline of my presentation today. Okay, so bronchiolitis is a disease of small bronchioles with increased mucus production and occasional bronchospasm, and sometimes it may lead to airway obstruction. Bronchiolitis is commonly caused by a viral lower respiratory tract infection and is most commonly occur in infants and young children. More severe diseases, more severe cases usually occurs in children. So bronchiolitis is potentially life-threatening, especially in the severe disease. So this is the epidemiology. It is the leading cause of hospitalization of infants and occurs almost exclusively during the first 2 years of life, with the peak age at 2 to 6 months. So many children with bronchiolitis can be managed as outpatient. However, premature infants, children with chronic lung disease of prematurity, congenital heart disease, neuromuscular weakness or immunodeficiency are at higher risk of severe and potentially fatal disease. So this group is also has higher risk to even get bronchiolitis. So in Malaysia, it is endemic throughout the year, where peaks occurs in the month of November, December, and January. Okay, so typically, bronchiolitis is caused by a viral infection, and the most common cause is respiratory syncytial virus, followed by this other virus, human metapneumovirus, parainfluenza, and rarely mycoplasma pneumoniae. So viral bronchiolitis is extremely contagious and is spread through contact with infected respiratory secretions. So even though cough can also produce aerosols, but the more common way to transmit this infection is through hand carriage, since babies, they like to touch things and put into their mouth. Okay, so this is the pathogenesis of bronchiolitis. The virus, it occurs when the virus infects the terminal bronchiolar epithelial cells, and which cause direct damage and inflammation in the small bronchi and bronchioles. So edema, excessive mucus and slough epithelial cells due to the inflammation may lead to obstruction of small airways and atelectasis, or collapse of the alveoli. So these are the clinical features of bronchiolitis. The typical illness for bronchiolitis, it usually starts with mild upper respiratory tract symptoms, and then after a few days, it will followed by lower respiratory tract symptoms. And initially, the patients may present with mild coryza symptoms such as nasal congestion, nasal discharge, or mild cough, along with low-grade fever. And then after a few days, about 3 to 7 days, the disease may progress, and they can present with other presentations such as persistent cough, increased breathing rate, raspy breathing and audible wheezing, feeding difficulty, which may be due to the increase in breathing rate or the nasal congestion, and also apnea, which is the cessation of breathing. In young infants, apnea may be the first sign of infection, as they usually present with the severe presentations of the disease. Okay, so these are the physical examination findings of bronchiolitis. So generally on inspection, we can see that they present with sharp and dry cough.
Inspection, observation you mean?
Sorry?
Observation lah.
General observation. Right. They present with sharp and dry cough, tachycardia.
Observation tachycardia.
Okay. So I did that wrong. So on general observation, we can observe that there is sharp and dry cough, and we can see that there are subcostal and intercostal recession, nasal flaring and grunting, and also we can see that they are cyanosis. So basically, these are the signs of respiratory distress. So the patient may also be tachycardic and also tachypneic. And on palpation, we can feel that the liver is displaced downwards and the sternum is more prominent. This is due to the hyperinflated chest, due to the hyperinflation of the lungs. Then on percussion, the chest may be hyperresonant because of the hyperinflation of the lung. And lastly, on auscultation may reveal fine and inspiratory crepitations, prolonged expiration, and also high-pitched wheeze or ronkai. Okay. So this picture shows the clinical features of severe bronchiolitis that usually occurs in infants. Okay, so on investigation, bronchiolitis is diagnosed clinically. Is a clinical diagnosis. It is diagnosed based upon history and physical examination. So routine laboratory tests are not required to confirm the diagnosis. However, it's important to assess the oxygenation of the patient, especially in severe bronchiolitis. Pulse oximetry should be performed in children suspected with bronchiolitis to maintain the oxygen saturation. Blood gas and chest X-ray are not routinely done, but they are only performed in severe disease or if the respiratory failure is suspected. And nasopharyngeal swab for respiratory virus is useful to identify the causative agent that causes bronchiolitis, and also helpful for grouping the children with the same infection in the hospital. So this is the picture, picture of the chest X-ray showing hyperinflation of the lungs with flattening diaphragm, horizontal ribs, and also increased hilar bronchial markings. So the differential diagnosis. So it's important to diagnose bronchiolitis. We need to differentiate the other diseases that also cause wheezing. So it's difficult to differentiate asthma and bronchiolitis through physical examination. However, there are several differential factors between these two diseases, which are the age of presentation, the presence of fever, and also if there are personal or family history of asthma. Like bronchiolitis, they usually present in younger children and in infants, and is usually accompanied, is usually in the presence of fever. Whereas for asthma, the age of presentation is more common in older children with previous episodes of wheezing. And also is typically not accompanied by fever. They don't usually have fever. And patients with asthma also usually have a personal or family history of asthma. And there are
a difficult issue because many of the patients with asthma, the trigger is a upper respiratory infection or lower respiratory infection. Because some asthmatic they have fever because of the trigger factor. So you really don't know, is it the viral-induced wheeze or is it asthma or not? That's why history very important.
Okay.
It can be have fever, it can be without fever, depend on the trigger factor. Lagi ya?
Also, there are also other diseases that also cause wheezing, such as foreign body in the airway, congenital airway obstruction lesion, cystic fibrosis, exacerbation of chronic lung disease, and viral or bacterial pneumonia. Okay, so this is a table showing the differences between acute bronchiolitis, asthma, and pneumonia. So as you can see, for example, the differences in the etiology. Bronchiolitis is usually caused by viral infection, whereas asthma is triggered by allergen, but can also be triggered by infection. And pneumonia, most common cause for pneumonia is bacterial infection. And also the risk factors also is different, and it's important to note where bronchiolitis, we can see they have higher risk if they are preterm infant and have congenital heart disease. Whereas for asthma, we can see if there has any atopy or family history of asthma. And for pneumonia, if there are presence of sick contact or immunodeficiency. And then the other differences, the history, physical examination, physical findings, and also the treatment. You can read this one. Okay, and then for the management, usually patients with bronchiolitis, they have mild illness and only 1% is admitted to hospital. So this table shows the guidelines for hospital admission in viral bronchiolitis. So in general, the indications for hospitalization is when there is moderate to marked respiratory distress, hypoxemia, if evident by the oxygen saturation, apnea, and also if there is inability to tolerate oral feeding. So if they have this condition, then they are indicated to be hospitalized. Okay, and the management basically is mainly supportive management, which includes respiratory monitoring, control of hydration and fever, and also oxygen administration if needed. So for hospitalized patient, we can oxygen therapy can be administered. We give humidified oxygen delivered via nasal cannula, and we should maintain the oxygen saturation above 93%. So this is determined by the pulse oximetry, and which also monitors signs of impending respiratory failure, such as rise of partial pressure of carbon dioxide, or if the oxygen saturation is not maintained. And secondly is the nutrition and fluid therapy. So infants admitted with viral bronchiolitis is usually associated with poor feeding and may have dehydration. So nasogastric feeding is useful for children who refuse feeds and to empty the dilated stomach. Intravenous fluid is also can be also given for children with severe respiratory distress, cyanosis, and apnea. And pharmacotherapy for bronchiolitis, we give bronchodilators, hypertonic 3% saline solution via nebulizer, which is known to increase the mucus clearance and reduce hospital stay among non-severe acute bronchiolitis. And we can also give inhaled beta-2 agonists, but regular assessment is required. Second, antibiotic therapy. However, this is not for all condition, only recommended to infants with recurrent apnea and circulatory impairment, possibility of septicemia, acute clinical deterioration, high white cell count, and progressive infiltrative
Antibiotic
changes on the.
therapy, you suspect the child got bacterial secondary infection. Finish.
Okay. Yes. All right.
Any
And then
questions? Apa severely affected?
so complications for bronchiolitis, usually it resolves completely without any complication. However, in severely affected patients, especially those who are premature or those who have underlying cardiopulmonary disease, they are at risk to have complications. So the most severe complications are apnea and respiratory failure, and they can and other complications include dehydration, asthma and secondary bacterial infection. And lastly is the prognosis and prevention. So prognosis, most infants, they usually recover from acute infection within 2 weeks, and most hospitalized children show marked improvement to 2 to 5 days with supportive treatment alone. And for prevention of bronchiolitis, monoclonal antibody to RSV, palivizumab, is said to give protection from the severe diseases of RSV. So it's given monthly through intramuscular injection, and is said to reduce the number of hospital admission in high-risk infant. However, it is expensive, and the use is only in the hospital. So that's all.
Any questions?
I have a question. For bronchiolitis, in the history, in the table that differentiate bronchiolitis, asthma, and pneumonia, in the history there is stated the happy wheezer. What does it mean by happy wheezer?
Dia wheezing lah, tapi dia happy lah. Dia wheezing, tapi dia happy. Wheezing can be many
It
cause.
doesn't affect that kid.
Happy wheezer is
means that the wheezing does
not diagnosis. Faham? Tunjuk gambar tadi, gambar differentiate tadi. Kamila, mana gambar yang differentiate tiga-tiga tu? Kamila? Mana Kamila? Happy wheezer is a condition. It's not a diagnosis. I mean, the child is wheezing at the same time dia apa? Dia happy lah. Lompat-lompat, tak ada apa, senyum-senyum, main-main, tapi dia wheezing. That's what happy wheezer all about. Causes of happy wheezer banyak. Viral induced wheeze, mild bronchiolitis, mild asthma. Now, all that can be a causes of wheezing. Faham? It can be just a upper respiratory infection that induce the bronchospasm, wheezing after that. Viral induced wheeze. Itu saja. There's no diagnosis happy wheezer. Happy wheezer is to describe the condition of the child is wheezing at the same time happy. If the child is not happy, you don't call it happy wheezer. Any questions?
Thank you.
No more question. Next presenter.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Ain Farhani binti Hassan, and I will present about the group and epiglottitis.
Siapa nama?
So, Nur Ain Farhani. Nur Ain Farhani.
Okay, present now.
So I will present about the group and epiglottitis. So this is the outline for today's presentation. So I will start by the group first. So group is also known as laryngeal-trachea-bronchitis. So as the name suggests, it's a viral infection that affect the upper respiratory airway, which is involve larynx, trachea, and bronchi. And it usually occurs in children between 6 months and until 6 years old. So there are many etiology or the causes of the group, but the most common pathogen is para-influenza virus. So the other pathogen that can cause group is respiratory syncytial virus, influenza virus, adenovirus, enterovirus, measles virus, mumps virus, rhinovirus, and rarely due to mycoplasma pneumoniae and corynebacterium, diphtheria. So next, for the pathophysiology of the group. So basically, for the pathophysiology of the group, it usually precedes with coryza or the fever, and when the infectious agent, when the pathogen will infiltrate the cell of the larynx, usually the cell of the larynx and the trachea, and this can cause a mucosal inflammation. So when there is a mucosal inflammation, this can lead to edema, and where there is edema, there is swollen tissue, and this swollen tissue can lead to a narrowing of the airway, and this can lead to the problem in the breathing. So for the clinical features of the group, basically the child will present with barking cough and voice hoarseness. This is due to the inflammation of the vocal cord. And when we do auscultation, we can hear harsh inspiratory stridor, and the patient can present with a respiratory distress based on the severity of the group. And usually the clinical features, it worsen at night and preceded by fever or coryza. So for the investigation to diagnose the group, the diagnosis of the group is basically clinically diagnostic, which is based on the symptom experience such as barking cough, preceded by coryza and others. But we can do further investigation if you are not sure about the disease or to confirm the diagnosis. So as you can see in the right picture, it shows a steeple sign which indicate of croup disease. And as you can see in the right picture, the arrow indicate the narrowing of the subglottic area. So you can compare between the normal upper airway and croup upper airway. Next, moving on to the management, treatment, and the complications. So if the patient presents to you with the group, first we need to assess their severity based on the vaginal. So this table show the clinical assessment of group using vaginal. The severity can be mild, moderate, and severe. So if the child had a stridor with excitement or at rest or had no respiratory distress, it might mean that the child might have mild group. And for moderate group, it categorized by stridor at rest with intercostal, subcostal, and standardization. And for severe group, it categorized by stridor at rest with marked recession, decreased air entry, and has altered level of consciousness. So this clinical assessment is quite important because it can decide what further treatment to give to the patient. So for the treatment of the patient, it can be treated at home and it can be admitted to the hospital. So it can be admitted to hospital if the child had moderate to severe viral group, less than 6 months old, and has poor oral intake, sick appearance, and had some difficulties such as leave far from the hospital. So after the hospital admission, we can start the treatment by giving oral dexamethasone or prednisolone to reduce croup severity by reducing the inflammation. And if the child had severe croup, we can give nebulized epinephrine or oxygen face mask. So for the complication of the group, the child can be complicated with hypoxemia and respiratory failure. It is due to the narrowing of the airway and bacterial tracheitis, which is the secondary bacterial infection. So moving on to the epiglottitis. Epiglottitis is the intense inflammation and swelling of epiglottis and surrounding tissue, and it can affect in all age group, but it usually occurs in children between 1 to 6 years old, and it is a life-threatening condition because it can obstruct the respiratory. So there are many pathogens that can cause the epiglottitis, but the most common organism is Haemophilus influenza type B. And this disease is rarely occurring nowadays because of the government had introduced Haemophilus influenza type B vaccination into our immunization program. So for the pathophysiology of the epiglottitis, so when there is a pathogen that infiltrate the epiglottis, this can cause effluent epiglottis. So when there is inflammation, there is edema, and this can cause swelling of the epiglottis. And swelling of the epiglottis can narrow the airway, and this can cause further obstruction to the child. So for the clinical features of the epiglottitis, so in the early stage, usually the child will present with high-grade fever, which is the temperature more than 38.5 degrees Celsius, and has ill, toxic-looking, and painful sore throat. And this painful sore throat will eventually progress to dysphagia, which is painful in swallowing. So because the child has dysphagia, they are unable to swallow their saliva, and this can lead to saliva drooling. And also in progressive stage, the child might have a respiratory obstruction due to the narrowing of the airway, and it can lead to the respiratory distress and dyspnea. And also, the child are prone to sit in the tripod position. So as you can see in the picture, the child is sitting upright and leaning forward, and the arm and the elbow is supported. This posture or position is important to maintain the airway open. And for the late stage of clinical features of epiglottitis, during auscultation, we can hear soft inspiratory stridor, and also the patient might have a cyanosis due to the respiratory distress and had concomitant bacteremia. So for the investigation of the epiglottitis, we can do X-ray or laryngoscopy. So in X-ray, you can see the time sign, which is indicative of epiglottitis. So this time sign is actually inflamed or a swollen epiglottis. And for the laryngoscopy, during laryngoscopy, you can visualize the epiglottis, and you can see that epiglottis is swelling, large, and has cherry red in color. So for the management, treatment, and complication of the epiglottitis, because epiglottitis is a life-threatening condition, so we must admit the child to the hospital quickly to secure their airway by doing tracheostomy or endotracheal intubation, and we can remove it after 24 hours. And also we can do taking blood culture for culture and sensitivity purposes. And for the treatment, we can give antibiotic treatment, which is given intravenously for 3 to 5 days, and it can recover within 2 to 3 weeks. And for the complication of the epiglottitis, the child can be complicated with pneumonia or airway obstruction due to the narrowing of the airway. So this table show the differences between the croup and the epiglottitis. So the onset of the croup is over days, meanwhile the onset of epiglottitis is over hours. And a croup has a preceding coryza, meanwhile epiglottitis doesn't have a coryza. And for the croup, the cough is severe and barking, meanwhile for the epiglottitis, the cough is absent or slight. And for the croup, the child are able to drink because they didn't present with dysphagia. Meanwhile, for epiglottitis, they are unable to drink because they has a painful during swallowing. And for the drooling of the saliva, for the group, it doesn't have drooling of saliva. And for the epiglottitis, it had drooling of saliva because it can present with dysphagia. And for the appearance of the group, it is unwell. Meanwhile, for the epiglottitis, it is toxic and very ill. And for the fever of the group is less than 38.5 degrees Celsius. Meanwhile, for the epiglottitis, it is high-grade fever, which is more than 38.5 degrees Celsius. And for the group, the stridor is harsh and rasping. Meanwhile, for the epiglottitis, the stridor is soft and whispering. And for the group, the voice is hoarse. And for the epiglottitis, the voice is muffled and reluctant to speak. So I think that's all from me.
The pathogenesis epiglottitis, dia punya, why is it we have not seen epiglottitis frequently now?
Because of the vaccination.
Of?
Vaccination.
Yeah, vaccination of what?
HIV, Haemophilus influenza type B.
Any other questions? Any questions?
I have a question. What does it mean by toxic appearance in epiglottis?
Toxic appearance. Toxic lah, saya nak cakap. Budak tu unwell, ill looking, apa you buat ialah you Google toxic appearance image. Okay.
Okay. Okay.
You Google toxic appearance image, nampak tu. Sebab benda tu kadang-kadang foto ni is more than 1,000 words. Kalau kita cerita pun you tak boleh imagine. So you sekarang ni nak belajar senang je. You just Google je sekarang. You buat toxic appearance children, you Google the image. You nampak budak tu bentuk macam mana very unwell. Any other questions? Any other questions? Siapa lagi nak tahu? Next.
Assalamualaikum warahmatullahi wabarakatuh. Can everyone see my slide?
Yeah.
Okay. I enter the presentation mode. Okay, so my name is Nur Azrin Farhana, and today I will be the last presenter for our seminar, and I present regarding the childhood pneumonia. Okay. Next. Okay, this is the outline of my presentation for today. We start with overview, definition, classification, pathophysiology, and the other thing as well in clinical features, complication, diagnosis, and also management. Okay, so firstly is the overview regarding pneumonia. Childhood pneumonia is a common condition worldwide, and the incidence of pneumonia peaks in infancy, and it decrease, but it is relatively high in childhood, but then it peaks again in older age. Virus are there are a lot of pathogens that cause pneumonia, such as virus, fungi, bacteria, but in clinical setting, virus are the most common cause in younger children, and bacteria are commoner in older children. And pneumonia is a major cause of childhood mortality in low and middle income countries, which include Malaysia as well. In Malaysia, the prevalence of pneumonia below age 5-year-olds estimated around 28% and until 39.3%. So firstly, we would like to know the definition of pneumonia. So pneumonia is the infection.
Presenter tu tadi. Azrin
Yes. Yes, me.
Azrin Farhana.
Nur Azrin Farhana.
Okay.
Okay, so firstly, we would like to know the definition. What is pneumonia exactly? So it is basically it's infection of the lung parenchyma, which involves the infiltration of the infiltration of the inflammatory cells into the interstitial tissue. So the pneumonia can be classified into firstly the anatomical classification, and it can be classified into etiological. So anatomical is based on where is the site of the pneumonia, site of the infection, such as bronchopneumonia, bronchopneumonia and lobar pneumonia. And etiological classification is based on how does the patient acquire the infection, such as community acquired pneumonia, nosocomial pneumonia, and also aspiration pneumonia. Okay. So how is pneumonia is process, the pathogenesis happens inside the airway. Basically, this is just a simple explanation of how the pathogens invade the airways. So firstly, when a person inhales the pathogens, and the pathogens can multiply in the alveolar space or the bronchioles. So the macrophage tends to produce cytokines, and then the cytokines can cause inflammatory process, and then can lead to fluid accumulation and also alveolar exudate formation. So as you can see on the right side is the fluid accumulation in alveoli, where this can cause a breathing problem in patient. Okay. So next one, this is just the overall of how pathogenesis and how the pathogenesis and it relates with the clinical findings of patient with pneumonia. So basically, when, like I say before, as the pathogen, there is exposure of pathogen. So it depends also to the host factors. And the risk factors for getting pneumonia are like immunological factors such as immunization status, immune compromised patient susceptible to get infection of the lung. Environmental factor also plays role, where secondhand smoking and air pollution can lead to decrease in immune system as well. Hospitalization can also lead to pneumonia because they are exposed to high pathogens inoculum, and also high resistant as well. And neonates,
Mana slide ni?
the one with, wait, the one with pathogenesis and clinical findings diagram.
You tahu,
Pathway.
it's not good to have a slide where, crowded macam ni. Crowded macam ni. And furthermore, it's good to have a slide that kalau you nak belajar better, you have your own slide. Macam ni tak belajar banyak. Lepas tu crowded slide, tu dah crowded. Not a teaching slide, this one. Kenapa you nak crowded semua dalam satu slide?
So this is basically just the summary of overall
Tapi
pathogenesis lah.
benda macam ni kan, I will tell you, you shouldn't crowded the slide.
Okay.
You pernah tengok IPZen slide penuh macam ni ke? Tak ada. It's not a good slide to present.
Okay, Doctor.
Crowded macam ni. You continue lah.
Okay, so I think everyone can just refer to this diagram for revision purposes after this. Okay.
You present apa? You kena present jugalah sebab you dah present ni. You kena explain the slide.
So continue on the other risk factor which cause a susceptible host to get pneumonia. So neonates and patient with underlying lung disease tend to get pneumonia due to neonates. Usually they have small airways and easier to get infection as well. So these factors also contribute to susceptibility of patient to get the pneumonia. So from the inflammatory process and so on, they can lead to other pathogenesis as well in the body, and can lead to these clinical signs and symptoms which we will discuss later. Okay, so the etiology of pneumonia is based on the age group. Based on the CPG, it is classified in each group. The specific etiological agents are usually not identified in 40% to 60% of cases because it is often difficult to distinguish viral from bacterial causes. And the pathogens for pneumonia, as you can see, it is better for to be divided into age group like this. Usually newborns had the pathogens for pneumonia are like group B Streptococcus, E. coli, Klebsiella, and Enterobacteriaceae. For infants, usually they had Chlamydia trachomatis because of vaginal delivery. And preschool age, usually they start to have Streptococcus pneumoniae, and but less common, and other Haemophilus influenza type B, Staphylococcus aureus, and less commonly the group A Streptococcus and others as well. In the school age, mostly it is Mycoplasma pneumonia and Chlamydia pneumonia.
You all kan nak tanya berapa presentation you all ada dalam 2-3 minggu ni? Dalam satu berapa 8 minggu ni? Each of you. 1, 2, 3.
This week.
Total in total.
For each student.
Each student. Berapa? 1. 3 ya? Each of you got present 3 kali?
Some of us once, some of us twice.
Twice.
9
weeks. Apa continue?
For viral, usually the common viral pathogens infect patient in preschool before the school age, usually in patient lower than 5-year-old. The pathogens are like respiratory syncytial virus, influenza virus, adenovirus, and parainfluenza virus. Okay, so next we go to the clinical features. Firstly, we would like to know regarding the history. In newborns, usually we should ask the mother whether the baby had poor feeding.
You type sendiri ke you ambil daripada you pick cut and paste?
I take and then I simplify.
Simplify. You cut and paste ke ataupun you type sendiri ke ataupun you cut and paste pada ambil?
Yes, I take from the resources, and then I make my own words. I type in simpler words.
Okay.
Yes, usually for newborns, we should ask mother that baby whether they had poor feeding, irritability, or grunting. In the first month of life, it would be most commonly presentation would be cough, and in older infants, they usually had persistent cough, fever, irritability, and decrease of the feeding.
Mana dapat first month of life cough? Children first month of life cough is uncommon because they have poor cough receptor. They present more of the takipnya. Continue. Okay.
And then baby would have noisy breathing sometimes, and for toddlers and preschoolers, usually they can have fever, cough, vomiting as well, and history of upper respiratory tract illness. And older children and adolescents, usually they also had fever and cough, congestion, chest pain, dehydration, lethargy, constitutional symptoms such as the headache, pleuritic chest pain, and also vague abdominal pain. Vomiting, diarrhea, pharyngitis is also the other common symptoms as well. We should also ask regarding travel history and immunization status and what type of medication did they had taken before. So next one is also the clinical features to show you that usually in viral bacteria, and mycoplasma infection, usually it had slightly different features. So for viral, usually the fever is low grade usually, and sometimes the patient can be febrile. Viral infection also patient come with upper respiratory tract infection symptoms such as cold and runny nose. And then they tend to have mild tachypnea, crackles, or wheezing. For bacterial infection, usually it was high fever, and this tends to be severe and comes with chills. Bacteria infection is very severe compared to other infection, and they can cause chest pain, toxic appearance, which is a very ill appearance, tachypnea, local dullness to percussion, cyanosis, and diminished breath sounds. For mycoplasma or chlamydia infection, usually this one is the disease in patient in older children, and the gradual onset of constitutional symptoms. The onset is gradual, and the cough tends to be worsening, and they have URTI symptom as well, and have dyspnea and crackles. These are the tables of symptoms and signs that we usually do check for pneumonia. So I already stated regarding fever, breathlessness, rapid and shallow breathing is a sign of a baby that wants to tahan sakit ke, macam itulah. And then runny nose usually because viral, I mentioned before, lethargy, restless, agitated, irritated. This is what we check in in history. Pleural inflammation, pleuritic chest pain, and neck stiffness and abdominal pain is also symptoms. So for signs is when we do the respiratory examination on inspection, usually we look where the patient had grunting, air hunger, tachypnea, had toxic looking, and nasopharynx, and also can come with intercostal retraction, which is the sign of respiratory distress. On palpation, we check that the chest movement is decreased. There is increase in tactile parameters. On percussion, there will be dull on percussion due to the pleural effusion and consolidation. On auscultation, there is also decreased breath sounds, bronchial breath sounds, cause crepitations, pleural rap, and increase in vocal parameters. And the signs that we should look in patient is the sign of respiratory distress, because this is very high in mortality rate. So patient can be fatal, and the signs are tachypnea, retraction, hypoxemia, nasopharynx, grunting, and use of accessory muscles, apnea, and also altered mental status. The signs which suggest of consolidated lung parenchyma will include decrease in breath sound, bronchial breath sound, and dullness to percussion. Meanwhile, for pleural effusion, usually there is chest pain, dullness to percussion, distant breath sounds, and also pleural friction rap. So this is the table to show you a simple table to show to differentiate between viral and bacterial pneumonia. The T is referring to temperature, as the viral infection usually had fever which is low grade compared to bacteria which is high grade. So the other symptoms I just mentioned before. So this is just the summary of what I explained. Okay, for diagnosis and investigation, what we can...
Sing balik. Tadi. Drills tu apa? Rails tu apa?
Rails is crackles.
Crackles apa?
Crackles.
Crackles tu apa?
Which is the high pitch sound when inhale and exhale.
Benda tu ada ke doktor you ajar? Lecturer you ajar Rails tu apa? I pernah ajar ke? You ambil, you tak faham benda apa tu. Rails and crackles is a US term for capitation. Faham? We Malaysia pakai apa?
Capitation.
Capitations, faham? Jangan pakai US punya ni. Very confused. You punya semua tak tahu benda apa. Pakai capitation. Crackles, semua tu Rails, itu semua US. Faham? Kita UK based ni kita pakai capitation, senang. Pernah ke you dengar lecturer you ajar kat mana-mana ni baca crackles Rails? Kita tak pernah you pakai that ni, jadi confusing. So capitation, tu you have to decide capitations. Scattered, localized, tak benar tu sebenarnya. But you talking about loba pneumonia dan loba probably control lah. WBC, okay, chest X-ray. Kalau loba yes, tapi bacterial pneumonia kebanyakan still broncho pneumonia, which is the capitation is scattered. Lobar pneumonia saja you localize the capitation. But lobar pneumonia is not common.
Okay, Doctor. So,
okay.
Yeah, proceed.
Continue.
For diagnosis and investigation, these are the lists that I found in the CPG as well. So firstly, we can do full blood count to check for the white blood count. So white blood cell count. So we should check for neutrophils and lymphocytes. And usually neutrophils will be elevated in bacteria cause, and lymphocytosis can happen in viral cause or severe overwhelming infection. Blood culture can be done and it is a non-invasive gold standard for determining the precise etiology. Usually blood culture is to diagnose bacterial causes, but the sensitivity is low and it positive only in 10 to 30% of patients. But if we get the blood culture negative, we cannot exclude bacterial causes. This is just to check whether if there is positive and what types of bacteria causing the infection and how to manage the patient later on. Serology is done in patient with suspected atypical pneumonia with infection like mycoplasma pneumonia and so on. But these serology tests are done only if in children 5-year-olds and older. Chest radiograph is indicated only when there is clinical criteria such as pneumonia. It does not differentiate etiological agents. So when we do chest radiograph, we cannot see whether we cannot diagnose whether the patient had viral or bacterial infection. So, then chest radiograph is also not necessary if the pneumonia is mild. Pleural fluid analysis is indicated for pleural effusion, and nasopharyngeal swab are done for viral causes, especially to check RSV. These are the example of chest X-ray, just to show that the X-ray on the left side is bronchopneumonia, which is the consolidation is scattered. As you can see in the diagram, is scattered and it is not confined in one space. Meanwhile, lobar pneumonia, this is the example of lobar pneumonia where you have the right upper lobe consolidated with a fluid, and it confined in just one lobe. Complications such as usually complication can happen in pediatrics such as pleural effusion, empyema, necrotizing pneumonia, lung abscess, and pneumatocyl. This is the example of X-ray and CT scan that were done to check for necrotizing pneumonia. And these are the example of X-ray done, and pneumatocyl is here where there is air sac in the lung. Next one is the management. So in order to do management, we should know what the severity of the patient first before we decide with what kind of treatment we want to do. So these are the assessment of severity in pneumonia based on the based on the protocols, and this helps in deciding what kinds of treatment, whether we want to do and we want to give antibiotics and other assessment as well. And the assessment of tachypnea should be referred to the this one, which lower than 2 months age. Usually tachypnea is more than 60 breath per minute. For infants, it will be more than 50 per minute, and for the toddler would be like more than 40 per minute. And then the other management is to assess assessment of oxygenation. This is a good measurement of hypoxia by doing pulse oximetry, and it is also good to assess the severity of pneumonia as well. Hospitalization will be needed if the patient had this criteria as below, where the children aged 3 months and below, and because they tend to have more complication and severe pneumonia. Fever with more than 38.5 and refuse to feed and vomit. Patient with fast breathing with or without cyanosis. Patient with systemic manifestation. Patient with failure of antibiotic therapy, patient with recurrent pneumonia, and patient with severe underlying disorders such as immunodeficiency. So the other management is the antibiotics. These are the list of antibiotics that are that should be given according to the specific pathogens. And for supportive treatments, just the fluid therapy, oxygen therapy, temperature control, chest physiotherapy, and cough medication, which are just to improve the symptoms. And this one is the outpatient and inpatient management that usually done based on the CPG. For outpatient, when the children have mild pneumonia, we should just give oral antibiotics and should educate and also educate parents for the management of fever and prevention of dehydration and identifying signs of deteriorate. The child should also return in 2 days for reassessment or earlier if condition is getting worse. For inpatient is much severe pneumonia, so we should give this suggested antimicrobial agents for the severe pneumonia. And it is important also to have high suspicion of Staph aureus infection, because some in patient with patient that had hospitalized before, so they tend to get Staph aureus infection as well. So we should give high dose chlorhexidine and do drainage of empyema if needed. The prognosis of pneumonia, usually it was the patient had full recovery and there is rapid recovery. Only few children may persist longer than 1 month or may be recurrent infection. So usually all children with pneumonia, even with empyema, they can make a full recovery if treated earlier. So that's all from me.
Any questions? Any questions? Tak ada, semua tahu dah. Tapi apalah you just now you have to know the differential between the bronchopneumonia, interstitial lobar pneumonia dan interstitial pneumonia. Three things, not just bronchopneumonia, interstitial pneumonia. And in terms of etiology, you must know, you try to think of how to differentiate between these bacterial pneumonia, viral pneumonia, or fungal. The third one will be chemical pneumonia. Chemical pneumonia is due to aspiration or inhale chemical toxic things, or aspiration. Aspiration is really chemical pneumonia. So this is how you divide the pneumonia. Interstitial pneumonia is another one you didn't touch. So you touch only bronchopneumonia and in bronchopneumonia and lobar pneumonia. Any other questions? Tak ada? Okay, finish that one. Any other question about the rest of the thing? Okay, your third year kan, please focus on physical examination, your clinical findings, which is the history and physical examination, because that is the crux for the third year. Management, so and so, we not bother so much about the management, because when you final year, you will be exposed more on the management, and furthermore, when you houseman, you're going to start manage the patients. So you should know the outline, but no need to know in detail. Don't waste your time to know the detail, wasting your brain space saja. Your brain space can be put something more important, especially the clinical features. If you present your lecture mostly clinical feature, I don't bother. I would prefer clinical feature daripada, I don't know why your slide is more in management, lagi panjang daripada clinical features. It seems to be a trend now in third year. I found that the management punya slide sampai 4 to 5 slide, whereas the clinical feature management slide 2 saja. Semua history, the sign and symptom, finish. Which is not to be in your final year, in your clinical year. Because we are focusing more for your student is the physical finding and then your history. Any other questions? Tak ada questions? Tak ada question, saya dah habis semua tahu semua benda lah. Dah tahu dah semua kan? Tak ada questions? I think you know everything about asthma already. Dah tahu semua dah? Tahu sikit? Or tak tahu apa yang tak tahu? Not sure apa yang you tak tahu? Tak boleh fikir. Asma ni tengok buku dia tebal ni tau, kalau baca buku asma apa-apa tau. Or you want to journal of asma, ada satu journal of asma for the past 20 years, 15 years journal of asma. So you imagine tebal mana. Is that all you want to know? You want to know everything about asthma? You know you cannot know everything about asthma, but you should know what is the important thing of asthma. That's all you need to know. And then to remind you again, palliative protocol is for doctor, not for houseman, not for medical students. Palliative protocol don't help you how to diagnose. It just tell you the diagnosis and then how to manage. If you read your palliative protocol as your main book for your third year, you're going to become stupid, because you won't get the core of the clinical knowledge yet. If you already houseman and then you already know how to diagnose asthma, then there's a time you use your palliative protocols, because palliative protocol is focused on management. Okay. Satu lah, the last thing is that Kalau you nak belajar, ya ingat, you better you take your time, type your own slide. Believe me, you learn more daripada you cut and paste. The more you belajar, you type on your own, the more you will learn. Because when you type on your own, you plan and you format your brain. Cut and paste ni, you ambil somebody else punya idea. I can show you. That's why when we orang lama, when we present, or when we present to the conference and meeting semua, we just cut and paste the tables, tu saja, tables, the the result tables, itu saja itu everything semua kita type sendiri. Because then we know what we want to present, we format our brain to what to present. Tengok you all habis daripada physical finding everything semua you all cut and paste. Lepas tu you all present, lepas tu another 2 weeks you lupa apa you present. Okay, finish.
Thank you.
Okay. Hi, Fadzil.
Malu tak ya, serius sangat muka.
Wah kau. Aku kena
Malu
contact
tu.
bila best time nak contact doktor?
Bila best time nak contact doktor?
Contact sehari sebelum.
Sehari sebelum. Okay. To remind je lah kan?
To remind. Nanti dia blue tick.
Okay. Blue tick. Aku minta outline tapi tu tak apa.
Kau dengan doktor siapa?
Aku dengan Dr. Fadzil juga.
Dr. Fadzil handle 3 seminar kan. Banyak juga.
You know. Baik.
Okay.
Good luck lah.
Okay, bye.
Ciao.
Nanti jauh lagi.
Saya suka sangat malu.
Tengok main book, malu tengok main book.
Tengok iPad.
Ya, iPad. Aku punya yang paling besar beli.
Apa yang kau tulis?
Yang ni untuk seminar aku Rabu nanti. Aku tak dengar apa aku cakap tadi.
Baik doh.
Bagus doh. Tanya Syafiq. Tanya Pak.
Try apa?
Tanya. Oh iya ni. You've done your best, bro. Keep it up, bro. You. Annoying kau.